Hello, everybody. My name is Garrett Schmidt. I am the managing editor and CEO of VBC Exhibit Hall, and I'd like to welcome you all to today's live webinar hosted by Roji Health Intelligence, which is one of our usuals here and one of our favorites, which I'll introduce our speaker in just a moment. But today's session is called "Are You a Latecomer ACO to APP Reporting? Your Last Minute Options." And I know there's a lot of you out there very interested in this topic, so welcome and glad you're here. A few items of note before we get started. Everyone has joined today in listen-only mode, so this is kind of a traditional webinar format. So you don't need to turn off your microphone or your camera or anything. We can't see you or hear you. But as I always say, we do want to hear from you. We're going to have some good time for some Q&A towards the end of the presentation today. So if you have a question at any point, and you don't have to wait until Q&A to ask it, go ahead and drop your question into your attendee module has a question spot there. So just go ahead and put your question there. And we're going to get to as many of those as we can today. If we run out of time or if we aren't able to get to yours for whatever reason, don't worry. Someone will reach out to you via email to make sure we get your question answered. Finally, today's session is being recorded. So what's going to happen is after we're conclude here in about an hour, you will receive an email that will have a link to the recording as well as to the slides for download. So hope you can share that with colleagues and friends, and you can rewatch it at your leisure, and hope that you do so. So without further ado, I wanted to introduce our speaker today. We have Ms. Terry Hush, and she is the CEO and founder of Roji Health Intelligence. So welcome, Terry.
Thank you so much, Garrett, and hi, everybody. I think it's going to be a little bit of a fun session today, so I'm trying to keep it light with some pictures and so on because if you are here, my suspicion is that you might be a latecomer ACO to APP reporting, so a little bit late to the party, or maybe you don't think you were late to the party since there's another year of the web interface, but I hope to persuade you that it's time to really get into gear if you need to do that. So let's get started. A little bit about us and why we're talking about this topic. We are a vendor in the value-based care technology space. We provide services to providers and a platform for looking at quality reporting as well as cost through episodes of care. Our tools identify patients at risk and target health interventions, and we help you meet both savings and quality goals and health equity goals for ACOs. We are a CMS qualified and ONC certified registry. That's important to the discussion today for APP reporting and all quality payment program reporting. And we report both ECQMs and CQMs, so we are on neutral ground on the topic of the approach, but we have a lot to say about it. So let's talk about whether you are late or not. So you're late if the train for APP is leaving the station. So yes, the web interface will give you an option, but once that train is out for the performance year of 2025, you are indeed lose all your options to be able to do methods of APP reporting that will be more aligned with your other objectives. I know there's been a big flurry over the last couple of years and continual pushbacks about the APP reporting requirements. Just a minute, one second. Have a little bit of asthma. But what you'll find out is that, one second.
We're working live here, folks, so appreciate you bearing with us. Terry will be back to us in just a moment. Get some holding music.
Terry just had to get some water.
Oh, there we go. Welcome back, Terry.
Yeah, I won't talk so fast, maybe, Garrett.
There you go.
So let's talk about the signals to watch to determine whether you're on time or on track. That's the train image here with a plan for APP reporting. So chances are you've been waiting for the final rule because you really want to maintain the web interface. And you and many other ACOs are in this boat right now because it's been a whole different world from what providers in the other part of the program and MIPS have been dealing with through quality reporting, reporting all patients, having to aggregate data, and so on. So if you've been waiting for the final rule and that's your reason for kind of stalling moving forward with the APP reporting, you're late. It also might be that you're still confused about what you really need to do. The methods of reporting, the difference in the reporting from the web interface really put you in a completely different scenario than they would if you were in the MIPS program. So looking at data, for one thing, a lot of ACOs are not as familiar with data outside of the claim scenario. Then that is a something you need to look at under APP reporting, which is brand new and it's also very expensive. So that kind of cost is something that many want to put off, but they don't also understand what the rules are really about and how that data really matters or the quality of that data. So what if we don't change at all and something just magical happens? Like, for example, that rule gets put off for yet another year. Um, if you don't have an APP reporting vendor yet, though, then what you're looking at is kind of setting a dumpster fire on your plan for APP reporting because now you have not any real significant guidance during the ramp up year to the final year of the web interface and coaching you through the process of data gathering and what data is really important, and then giving you continual feedback on the quality or integrity of the data you actually have. Or you may be kind of in Disney World and you can't really decide on what kind of method you want to do for APP reporting. So it's better just to wait and kind of magically figure that out over time. Or, as many ACOs don't, you don't really have a lot of information about your practice EHRs. So your participants have most likely a variety of different EHRs or different instances of the same EHR. They don't communicate with each other. The practices themselves may not have the kind of technical staff that it can even serve up that data. And so that just looks to be like a horrendous obstacle to gathering the data that you need for APP reporting. But lack of that information will create kind of a wasteland in front of you, which is what you're looking at right here. And you're late if you haven't collected any data yet. And why is that important? Because without looking at data, you don't know what you're missing, and you don't really understand whether what you can tweak to improve your position under APP reporting when it gets here. So if your belief systems were driving your quality reporting strategy, then what you really need is a latecomers strategy for year one. And I'm talking year one, 2025, so that you can start preparing for the mandatory reporting in 2026. So now I'd like to figure out where you actually are before I go on so that I can address that. And here are the questions. You can consider yourself late under these definitions. You have to use these definitions, not how you might think of it. Or you're on target, you're actually proceeding with some of these things and moving forward with APP. And a third is like, so what? There's still a lot of time. Garrett?
Okay, so it is should be launched on your screen right now, and this is a choose one that best applies. And these are anonymous, by the way. And we'll show the results here shortly so you can see where you stack among your colleagues. So it's okay to be honest here. No shame here. That's why we're here.
That's why the pictures are funny.
That's right. That's right. Okay. I think most people have voted at this point. We're going to give it another 5 long seconds here. Either we're late or we're on target or so what? There's still time. Okay. I'm going to close it down in 5, 4, 3, 2, and 1. All right. Terry, so here's our results. 27% of you said we're late. 59% of you said we're on target. And 14% said, so what? There is still time.
All right. Well, that's good information. So I'm very curious as to why those who think they're on target are in the webinar today.
Are here?
Let's not be sure that you're really on target. That's my
Hey, never be
suspicion.
too sure.
I would be very interested in a question related to that that would highlight something at the end of the presentation.
Okay.
All right. Moving on to the facts on APP reporting 2025. So we're expecting the final rule to come out within a few weeks, and that will give us the certainty that there will not be an additional delay for APP reporting, and there may not be changes to the proposed rule. But one of the questions that I think that we're interested in seeing in particular is, will APP reporting through MIPS CQMs, which were permitted this year, be permitted in 2025 and going forward? There's been a lot of comments about that, and I think with good reason, because they give ACOs the flexibility to use a lot of different data sources. And as I said, we're neutral on the actual reporting method, but we think it's an advantage to ACOs to actually be able to use CQMs. But both reporting methods require data collection for both numerator and denominator values. And there's a little bit of a surprise coming on that one in just a few minutes. So measures in the APP, there's active reporting required for 3 measures: diabetes, hemoglobin A1C, preventive care and screening, controlling high blood pressure. You know that's going up in 2025. Measures are calculated also by CMS and survey vendors. So, but what we are really focused on today are the active reported measures that will be continually ramped up over time, as you will see. How the reporting options compare. ECQM still applies to all eligible patients. That means any patient that is triggered a measure. It does not allow for changing any value that comes from the electronic data source for ECQMs, which is the QRDA1. And therefore, the denominator calculation is made by a third-party intermediary, which is collecting that data to determine the eligibility of the measure, of the patients for the measure. Medicare CQMs apply to Medicare patients only. It does allow manual intervention, meaning that data sources can come from a variety of things. They don't have to be in the field in the EHR to be exported to a particular format. And here's what's new is that the denominator calculation, which CMS in the original rule said would come from CMS lists of eligible patients, just this last month, they clarified that those lists need to be backed by aggregated data from the ACO, meaning that there still must be some data collection, which we could be practice management type data or billing data or EHR data that has the demographics and basic billing information. So it's not as easy as it was going to be. It is going to be a little bit higher bar to be able to aggregate just the practice management data, but not impossible. So either way, the denominator calculation is going to require some data aggregation from all practices. And just to be specific about the reporting denominators, if you're doing APP reporting via CQMs, the electronic calculation of that data comes from QRDAs, and it covers both the denominator and the numerator of the measure. And it's fed up by the EHR in their, as part of their certification, they have a program in it that creates this document, a QRDA1, and then in the system turns it into a QRDA3, which is the reporting vehicle to Medicare. When you're an ACO and you're looking at that from multiple practices, the QRDA1 is what's significant to be reported to your intermediary so that they can match the patients across all of the systems and have a unique patient ID for the ACO. So it's a little bit different than what happens in EHR reporting in MIPS, where it's completely seamless. It's not, it's a little bit more complicated. Now, on APP reporting with Medicare CQMs, the CMS quarterly list of eligible patients is one thing that you can use, but ACOs now must validate the denominator data using their own data. So you can't just depend on the CMS list. CMS will be checking that when they do audits, and that will be a required. So it's a little bit of a bore here, BOAR. On the numerators, all APP reporting requires data collection for the numerators as well. APP reporting via CQMs come in on that same QRDA. So it's the same document, suffices for both. And APP reporting on Medicare CQMs can be manual. It can be aggregated by your third-party intermediary in flat files. It can come in through QRDAs. You can use a variety of different tools to gather the data for numerators and CQMs that you can't use for eCQMs. It must come through the QRDA on the eCQM. So let's talk more about the eCQM method. All patients under CQM is an exact science, meaning that it really must be, all patients must be collected in the aggregation of data, and patients are matched across all practices to create a unique patient ID. You can't have a situation in which one practice does not have the ability to export those QRDA1s, meaning there may not be on a certified system, or we'll go into some of the other reasons. But it must be all practices can report the exact same thing. You can't have some practices being able to report QRDAs and some practices a different kind of format, say a report coming out of the system, or eCQMs is not the option that you may use as an ACO. It has to be everything. Here's the issue. Not all certified EHRs can produce QRDA files for external use. As I mentioned, these are designed internally as a process for EHR reporting, primarily under MIPS. It could be used under ACOs if you only have one system covering all of the participating providers. But in the QRDA1 is meant to flow through the system into a QRDA3. That's what it means when they say interoperable. The data is going in, it's being stored, it's being retrieved by the system, and it's being exported and directly reported to Medicare. So that's a different kind than we're looking at for aggregation of other data sources. Practices with a customized EHR have particular problems because they often will create templates for specialties. And when the QRDA certification process was organized, perhaps that template didn't exist, or the organization didn't buy a certain functionality with the EHR, and so the QRDA is blank, or it's a blank template, or it simply is not able to produce real data files. So every practice needs to be able to check this. This is part of the lateness issue because you need to know when you're going into an ECQM, if you've decided to go in that track, that you can actually produce the QRDA1 from every single practice and that those files have data in it. You're not missing big values. So as I mentioned, this kind of Bozo the Clown, Frankenstein mix here. Interoperable data sounds like data just flows. It just goes the right place and it hooks up. That is not the way it really works. QRDA files are interoperable only within the same EHR system. They don't meet the system-to-system aggregation that ACOs will be using for APP reporting. And that's because they don't talk necessarily. Your vendor will have to make that happen by collapsing all of the QRDA1 files and matching those patients in order to make it an interoperable. And it also means that when you choose your vendor, you will need to search, and you want to do ECQM reporting, that you will also need to make certain that your vendor is ONC certified as well, so that they can actually consume the QRDA ones and turn them into the reporting tool for Medicare. As I mentioned, the QRDA1 files are tools for EHRs to collect that data and report it through QRDA3s. QRDA3s cannot be used for APP reporting. They are the report that is the summary of all patients. That is not what can happen with ACOs because it doesn't match the patients. It doesn't apply the criteria you need for quality reporting. So when will ECQM reporting work best? Well, it will work best for larger ACOs that are on one system or practices that are on one or more systems that are ONC certified with tested capability to produce QRDA1 files with data. And that is not an obvious situation. We have received QRDA1 files that are blank from big systems. So it really depends on the installation of that system and how that QRDA1 file was constructed vis-a-vis the usage of the EHR. It will also work best in certain conditions. If you need a faster time frame for APP reporting with the ECQM method and you have tested the data, then ECQMs will be pretty fast. It is not to say that there won't be a requirement. However, all those QRDA1 files are produced in a format that needs to be converted into a different program to be consumed and matched. And so there will be requirement on the vendor side. It isn't instantaneous to get QRDA1s ready. It will be more expensive, without a doubt, to use ECQM reporting because there are, number one, more patients involved. It means reporting all patients who are eligible, regardless of their coverage status. It's not just Medicare. There will be more data in it, and there will be more processing time and more storage of that data for QRDA1s. They are big, fat files. The data value, and I think this is an extremely important consideration for the overall future of your data efforts. The data value of QRDA1s is limited to quality reporting. There's very little that you can do with that because the QRDA1 is specifically designed to meet a measure, and it doesn't give you all the other outcomes associated with a patient. For example, you will get the hemoglobin A1C. You will not get the other outcomes related to that patient, like obesity or different types of cardiac disease or other issues that the patient may have. You will only get the measures that are going to be reported. So let's talk a little bit about the Medicare CQM. Here you've got limited patients and limited data. CMS identifies the eligible patients quarterly. You will need, because of the requirement that ACOs validate the CMS lists now, you will need to update and aggregate that data more frequently so that it can feed your ongoing process of making sure that you're successful with reporting. The ACO will have to validate the denominator and they will have to meet the measures, both things. This can work for ACOs that are big and small. The larger ACOs will require more data aggregation just by virtue of the need to deal with the numerators and providing numerators to this data. They will not want to be doing any kind of manual input of hemoglobin A1C values or anything else. But you can get lab data and import it. You can use a variety of different data sources in addition to the EHR that can provide the values and minimize the manual input of measure values. But smaller ACOs, those with a very small number of patients, may want manual input of the measure values because it will lower their prices for actually APP reporting through the Medicare CQM. So I think one of the things that we do is we provide several different plans for APP reporting for Medicare CQMs specifically, depending on the size and capacity of the ACO to collect data. And that way, we can tie our plans in with the economic value of the product and also with what the ACO wants to do. You can also use multiple electronic sources of data in Medicare CQMs or any kind of CQM reporting. But quite frankly, the Medicare CQM product is a backhorse. Things are being hung on, like the need to validate the Medicare list. The use of the Medicare list is a new thing. There's no Medicare eligible list in the MIPS program, for example. And in reality, we're talking about an environment in which we're going to be weaving multiple data sources and capabilities, and it will require more innovation, flexibility, and a real opportunistic approach between the vendor and the ACO to be able to reach the right level of workload for the ACO to try to minimize that and balance the successful reporting. So that data strategy for Medicare CQM is going to rely on variable sources of data The data aggregation should maximize electronic sources of easy to get data, not spend a lot of time on QRDAs, for example, because QRDAs are not necessarily easy to get. But you can use flat files. You can use exportable reports from EHRs. You can use lab files, as I mentioned, and all of those then claims data will provide some demographic billing data will provide information on the patients and basic diagnosis codes that will meet the measure and trigger it. And all of those can be compared with the CMS lists. And so it's demographic billing, some EHR data, clinical data, the CMS eligibility lists. What we're really looking at down the line is EHR systems with FHIR and flat files to make the process of gathering data cheaper and more fluid and contain the highest value of data that the ACO needs to have, not just for quality reporting, but for their cost initiatives, for population health, for all of their efforts. So how to reap value through the Medicare CQM report. CMS intended here to appease ACOs by limiting the scope to Medicare patients only. It was supposed to be lighter, but the reality of that now, with the need to gather data from the ACO and not just work off the Medicare lists, is a lot different. It does mean that it's more complex to be able to meet the Medicare CQM requirements than we understood it to be initially. The smaller ACOs will have fewer patients to report, but there will be data challenges and there will be some reporting burden. The data challenges will come because smaller ACOs tend to have older systems in practices, systems that are not certified, systems that is difficult to get data from. And so that needs to be taken into account when you're looking at any of these approaches. But if they have those kinds of systems, they would be excluded from the ECQM approach anyway. The large ACOs must aggregate the major sources of data to be able to report on any of that, to validate the list, to be able to report the measures. They're definitely going to want to use a data aggregation strategy, regardless of ECQMs and CQMs. It's just a matter of which data gets collected. The fact is that there's a myth out there that ECQMs, being the quote interoperable method, is less work, and that it's better than CQMs, they're more modern or whatever. It is not true. Neither ECQMs or CQMs are easier or better in sense it will make your reporting more successful. Both of them are the same. They're both grounded in data that comes from the EHR, and for CQMs, you have the advantage of different or other valid data sources. Both of them have some challenges if the data is not easily obtained. You have an issue with the value of QRDA ones being more expensive to do ECQM reporting, and what do you get for your money. But the bottom line is the most valuable method of reporting is the approach that will produce the best results for your ACO in both workload and quality results. So let's talk a little bit about practical strategies to catch up in 2025. Well, first of all, this is an extremely complicated arena. You need experienced help. We don't usually say that because it sounds like a real big sales pitch, but we're not the only ones out there either. You need experienced help to be able to guide you through the process and answer questions. We have a lot of ACOs coming to us with things they do not understand about data. And having a coach go through this process with you is essential. You need not just experienced help, but you need help in the type of environment you will have, which more mirrors the old clinical integration environment with multiple practices, multiple systems, than it does a single practice or a big organization. You should have someone with 10 plus years experience who has been reporting MIPS for a long period of times, doesn't have any dings on their record from CMS, is authorized for both ECQMs and CQMs, and is willing to put on the table a data strategy for your organization once they have the information about what that is. It's and here's the full list, which you'll find in the slides once you download those. Say a little bit more about the data strategy. It's of benefit to ACOs to be able, as I mentioned, to have the highest value of the data that you're going to spend all this money collecting. And it doesn't need to be, enormously expensive to be a costly process. When you have data, you want to be able to use it in your other programs. You need to be able to evaluate your SDH reporting within your data. You should be able to expect that from your organization. You should be able to understand that your data has integrity or what kind of data it's missing so that you can help lead your participating practices down the line of actually helping to get them standardized systems. You may develop a strategy for collapsing and standardizing systems for them as the rule is insisting that you do. But without some kind of guidance to be able to do that, it will be very difficult. Fire readiness is an extremely important thing to ascertain from your practices. The future is not ECQM as currently defined. The future is digital quality measures, and those are coming down the line. We don't know the date yet, but those will be fed by FHIR applications, which collect a lot more data in a cheaper for all the participants involved, and will be truly interoperable for all organizations. And you also want to be able to plug and play with your other software. If you've collected all this data for quality, you want to be able to use it in population health. Second is to start gathering the information you need to be able to go out there and evaluate vendors. You need volume metrics to be able to say what the size of your organization is so that they can understand the level of the work involved and be able to plan for that. You need to know what your practice systems are and the versions of those practice systems. How antiquated are they? And what modules have your participating practices not bought? For example, you can purchase a practice management or an EHR, but not buy the reporting module. And not buying the reporting module means that you can't export any data on your patients to anyone. So it is a real issue for a lot of EHRs, and we have seen this over and over again, that the practice evaluated EHRs went through a big deal to do it, chose a vendor, did not buy the reporting module, and they're stuck. So I think that one of the things I didn't mention in that list, and I think this is extremely important, face the number one issue that you will have, which is to verify and ensure that QRDAs and FHIR capabilities are in the systems in your practices. And if not, work with those practices to identify their options. Third strategy is involving your clinicians in the workload, because a lot of the work that will be done for quality reporting, especially under Medicare CQMs, will be done by practices because for smaller ACOs, it will almost certainly require that there be some manual input because the data can't be found or exported by the EHR. So what are those decisions? Well, number one, it's determining the tolerance for manual input of patient measure values. Because if you don't have any electronic source for that data and the system can't export it, then it will have to be input. And that is a big job or a little job depending on how large your ACO is or how large the practice is and what your division of workload is going to be. Identifying other sources of electronic data to capture will be important. A lot of times clinicians actually have some of those sources of data that they use independently and have been tracking and can be used as long as they can be verified and validated with the EHR at the end. Tools at point of care if there's no EHR. If they're collecting data or you can help them collect data and develop that into an electronic input as opposed to a manual input, that would be better. And then you need to press your vendors for assistance and how to do this. They've been through this before with other environments. They understand what it is to create tools at practice levels. So if you have not included that in your questions of potential vendors, you should. A fourth thing is that we need to all understand that what we're building for is a future, not the current QPP, APP reporting method, because digital measures are coming down the line. And what will they entail? And AI is coming down the line. So there's a lot of different things happening that will require change in all of the practices that we have right now and in ACOs. Data is going to be of much higher value in the future than it has been in the past. And so developing a system strategy of how you deal with data is a really important goal for ACOs and one that many ACOs are beginning to focus on right now. Testing your data exports, building internal consensus for what you need to do, and piloting FHIR are all on like my high list for what organizations need to be looking at right now. I want to make a particular comment on developing a better system strategy for data, for housing data, because there's so many options. You can choose to allow individual practices to continue to choose their own systems, or you can develop a model in which you've chosen or you're sponsoring a couple of different systems for them to choose from so that you can reduce the struggle of data aggregation, yet still have little price variation going on for the practices. But all of that requires building an internal consensus among clinicians and practice managers for adopting new systems to begin with. If they've already gone through one system adoption, it's really a big struggle. And so it will be a long process for some of them. But for a lot of the old systems, you may find some eager listeners on that one. Whatever you do in this regard on how you're planning for the future of your data strategy, piloting FHIR is one of the key things to be paying attention to. You need to really make sure that you've got EHRs that have a sandbox so that applications can be created and that those sandboxes are actually working. Not all are. And that it makes it inexpensive to anybody, for everybody to move forward with fire connections and fire applications. And then finally, creating value for your investment in the data. Um, Looking at the multiple uses for quality data, looking at how you can improve your cost performance is a key thing that many ACOs have not really focused on. Looking at your specialty care services, 40 to 60% of the cost, and yet not a lot of effort there because of the lack of data. But looking at different sources of data, identifying data in your specialty practices that you're referring to, all of that is coming onto the horizon and needs to be in the talking mode at this point, but definitely part of your long-term APP reporting vision. So a little wrap up is my favorite little outlet. If you really have put off reporting, APP reporting in 2025, um, I have to urge you to think about that again. But in any case, CQM reporting will be your safest bet for a quick start because you don't need to do as much spade work on the practice systems as you do with ECQMs. CQMs can be done with a lower reporting burden. If your EHRs are modern and appropriately used, they should be able to export the data. But you should use the expertise that you're purchasing with the review of your organization to be able to make those decisions. There are situations where I would say definitely ECQM all the way. But for most of the ACOs that we are seeing with multiple systems, it is a tough, tough road for the early one. Build for the future, though. Consider your first year, especially 2025, if you're going to do it, as your practice year. Identify the errors that are coming through, where are the holes in your systems, the holes in your data, and your performance, and build it for 2026 in a way that actually is tested. And now I'm available for any questions.
Okay, so we've got a number of questions. And first of all, Terry, this is a fantastic presentation. Obviously, there's a lot here. And so I'm sure there are questions. If you have a question that you would like to ask Terry, go ahead and drop that now into your attendee module. You have a place for questions. We're going to get to as many as we can. So here is the first one, Terry. ECQM reporting seems to be a heavy lift for ACOs. We know that QRDA1s are a requirement for ECQM reporting. What are the challenges and disadvantages of working with QRDA1, as it would seem that it is not automatically interoperable with systems and requires a lot of work?
I think there's two big challenges. One is that it's more expensive to do ECQM reporting because it's a higher number of patients, and QRDAs are uncertain at best in most of the ACOs that we have encountered. It doesn't mean that an ACO with a couple of major systems, you have Epic, Athena, that you'll find ECQMs to be a valid and easier approach. QRDA ones are more expensive. It will raise your cost for reporting in the first year. But it will also, it could reduce your burden. It really depends on that answer to that question. Who are the systems?
Got it. Okay, next question here is, do we have the option to straddle the fence and report both ECQM and Medicare CQMs for our ACO? And if so, what impact would that have for us?
Nope. Nope, you don't have the ability to straddle the fence. Now, that said, you may have a plan. that says we really want to report ECQMs if we can. Again, as I said before, one is not better than the other. Don't be fooled because they come in with this interoperable label when they're just electronic data. That's all they are. Both cases, electronic data. They don't feed like fire feeds and they're lower valued. So you still may have a plan, and you might want to say, we just know we don't want to spend any time gathering data from anyone. We just want this to be produced by our magical EHRs and get on with it. A vendor might say to you, sure, we will go down that road with you. And if we can't get all of the QRDA ones from every system so that you can report for the entire ACO, because you can't do it if even one of your practices can't produce the QRDA ones. Then we can drop down and do Medicare CQM. They will charge you, though, at the level of the Medicare CQM. So, because that makes sense, they've already done the work on that kind of conversion of the data and, storage and, effort, level of effort to spend at QRDA ones. Or they may charge you a blend that would add on Medicare CQM. So I wouldn't advise it. I would advise going, what my favorite strategy is start with the understanding that you'll probably do Medicare CQMs, but convince your vendor to help you during the year to test QRDA ones as an option for most of your systems. That way you end up with both.
Gotcha. Okay, next question here, moving right along, is it would appear that CMS views Medicare CQMs as a stopgap to full ECQM reporting. What recommendations would you suggest for our ACO as a strategic map to plan ahead for our future reporting processes?
I do believe that that is the case, that it is kind of a stopgap, because Medicare wants everybody to report all patients. That's been the way it has been in the MIPS program for so many years, and they want everybody to have parity across the entire spectrum. But I would definitely take the Medicare CQM gamble if it is easier for you and if you're going to be successful. Whatever works for you, as I said, is the way to go in the early years and test your strategies. And ECQMs are not the goal. Digital quality measures are the goal. Digital quality measures are hooked to a different data source than QRDA1. I would hold out as long as you can until that happens.
Indeed. All right. Next question here is I know we still can use MIPS CQM for PY 2024, but what are the odds that CMS will consider keeping merit-based incentive payment system MIPS clinical quality measure CQM reporting method as an option for 2025 and beyond?
Well, I think it's a pretty good option for 2025 because they have it in the proposed rule. They're not going to limit that in the proposed rule for 2025. 2026, I think it will be surprising if they limit it and go to a requirement that organizations do ECQMs only. I think it is more likely that they would ramp up the time frame for digital quality measures and start moving in that direction. But these are long-term questions. I don't know. No crystal ball on this one. It's a danger, but I don't think it's a significant danger.
Okay, anybody's guess, I suppose, what's going to happen. Um, All right. Well, that is actually all the time we have today for questions. So, thank you, Terry, again for a fantastic presentation. This was wonderful. And if you are still here with us, we're going to we're going to send out the recording to today's session, and so you'll have that, and you can rewatch that. And if you have any other questions at that time, then of course you can reach out. But as we conclude here, wanted to encourage you all to head over to vbcexhibithall.com and check out the Roji Health Intelligence virtual exhibit booth that's there. Terry, can I have you advance that slide? There we go. And so that's what it looks like. And there will be a link on the slides where you can go there and visit that directly. But you'll be able to read up on them and see what Roji's doing in the space. There's a lot of great resources that they have. And of course, through that, you can reach out to them. There's also a lot of great resources in our library uh, where you can see other webinars on these topics and a lot of articles and white papers and so on. So hope that you spend some time with us there. And of course, it's all free to the public. So for you to enjoy. And then as we close, if you would like to reach to Terry directly, you can reach her here. And her, well, let's see, actually, yeah, no, her information is here. And also Leonard Ho, who will be able to help you, and either of them will be able to guide you in the right direction. And I've known Terry and Leonard for a long time, and Roji is a wonderful and fantastic company. So you would be in good hands if you choose to work with them. Or if you would like to reach out to me, I'm happy to facilitate an introduction as well. Thank you all again so much for spending your afternoon with us. Terry, glad you survived your asthmatic episode there early on. We will see you on the next one. Bye, folks.
Hmm.